Hello everyone, I'm Dr. Anupama Chowdhry Devgan, your physiology faculty. And this is Physiology in Small Doses. This is a quiz of 10 questions from high-yield topics for the FMGE exam. So let's have a look at the first question. It says, death due to cyanide poisoning results from which of the following types of hypoxia? We know there are 4 types of hypoxia. There is a hypoxic hypoxia, which occurs in high altitude, in hypoventilation due to any cause. In hypoxic hypoxia, there is a decrease in PO2 and a decrease in saturation. And anemic hypoxia. In anemic hypoxia, either the hemoglobin is reduced or its saturation is reduced. But please remember, the PO2 here is normal. What are the examples of anemic hypoxia? Iron deficiency anemia, megaloblastic anemia. Here the hemoglobin is reduced, but PO2 is normal. Another example of anemic hypoxia is carbon monoxide poisoning. Here the hemoglobin is normal, but its saturation is reduced. So again, PO2 will be normal. So this is anemic hypoxia. Stagnant hypoxia. This occurs in cardiac failure. In stagnant hypoxia, there is an increase in the arteriovenous oxygen difference. Normally, the arterial PO2 is 95 millimeters of mercury, venous is 40. But in stagnant hypoxia, when the blood flow rate reduces, when the blood is moving slowly through the capillaries, this difference between the arterial side and venous side, the PO2 difference, will increase. And the 4th type is called histotoxic hypoxia. In histotoxic hypoxia, the cells are unable to utilize oxygen. So what will happen to the venous PO2? Increases. So what happens to the difference between the arterial and the venous PO2? It reduces. This is typically seen in cyanide poisoning. So cyanide poisoning is what type of hypoxia? Histotoxic. Cells are unable to utilize oxygen. Let me just explain this decrease in arteriovenous oxygen difference. Now, when blood comes from the arterial side of the capillary, the PO2 here is 95 millimeters of mercury and the saturation of hemoglobin is 97 to 98%. These are typical arterial values. And as the blood passes through the capillaries, oxygen moves to the cells and CO2 from the cells into the capillary. So that on the venous side, the PO2 now reduces to 40. The saturation of hemoglobin reduces to 75%. These are the changes taking place in the O2. What about the CO2 levels? PCO2 on the arterial side is 40 millimeters of mercury, and this increases to 45 millimeters of mercury on the venous side. So if I look at the arteriovenous oxygen difference, I'm referring to this difference in the PO2 in the arterial and the venous side. Normally, PO2 is 95 on the arterial side, venous PO2 is 40. Difference is 55 millimeters of mercury. But if there is histotoxicity, like for instance in cyanide poisoning, the tissues are unable to utilize oxygen. So what will happen to the venous PO2? It will increase. So what will happen to the arteriovenous oxygen difference? It will reduce. Instead of venous PO2 being 40, now maybe 50 or 60. So the arteriovenous oxygen difference will decrease. So this is typically seen in histotoxic hypoxia. Under normal conditions, maximum calcium reabsorption occurs in which of the following segments of the nephron? Now please remember, it is the PCT which is the site of maximum reabsorption of most solutes, including electrolytes. So sodium, potassium, chloride, bicarbonate, calcium, their maximum reabsorption occurs in the PCT. There is one electrolyte, and that is magnesium. For magnesium, the maximum reabsorption is not in the PCT, but in fact in the thick ascending limb. So since this question says calcium reabsorption, the answer is without a doubt PCT. A 30-year-old male has a total body water which is 60% of the body weight. So normally the total body water is 60% of the body weight. This total body water is divided into two compartments, ICF and ECF. 2/3 of the body water is in the ICF, 1/3 in the ECF. In terms of percentages of body weight, this is 40, ECF is 20% of the body weight. ECF is further subdivided into plasma, which is 5% of the body weight, and interstitial fluid, which is 15% of the body weight. 3/4 of the ECF is in the interstitium. So this says ECF and ICF as percentages of body weight in this individual will be which of the following? Now, if you look at this, ICF I said is 40, ECF is 20, but the question says ECF and ICF. So in that case, my answer becomes 20/40. ECF is 20% of body weight and ICF is 40% of the body weight. Remember, 2/3 of the body water is in the intracellular compartment. Most of the body water is inside the cells. Let's look at the next question. In the erect posture, VQ ratio is highest in which part of the lung? V is ventilation, Q is perfusion. Now, in the standing posture, in the erect posture, that means basically because of the effect of gravity, we find that the VQ ratio at the base is 0.63 and at the apex, the VQ ratio is 3.3. At the level of the third rib, which is close to the hilum, the VQ ratio is 1. A low VQ ratio at the base means that it is a low PO2 and high PCO2. At the apex, it will be a higher PO2 and lower PCO2. See, remember when we say VQ ratio is 3.3 at the apex, that means ventilation is in excess of the perfusion. So that means whatever blood flow is at the apex, it is very well ventilated. So higher PO2 levels at the apex. And that's also the reason why tuberculosis is common at the apex. Mycobacterium tuberculosis is an air-loving organism. So the hematogenous spread in secondary tuberculosis will occur to the apex because of a high PO2 level at the apex. So VQ ratio is highest at the apex, but this is in the standing position. The moment you lie down, then these gradients will be lost. The major neurotransmitter secreted by the substantia nigra pars compacta is dopamine, and loss of substantia nigra pars compacta neurons, loss of the dopaminergic neurons, is responsible for Parkinsons. A brief recap of the different components of the basal ganglia and the neurotransmitters that they secrete. The parts of the basal ganglia: caudate nucleus, number 2, putamen, number 3, globus pallidus. Globus pallidus has got two parts. There is an external segment and there is an internal segment. Substantia nigra, there are two parts again, substantia nigra pars compacta and substantia nigra pars reticularis. And the fifth is the subthalamic nucleus of Lewis. The caudate nucleus and putamen together are known as the striatum. 95% of the striatal neurons will secrete GABA, 5% secrete acetylcholine and somatostatin. Globus pallidus external segment secretes GABA, internal segment also secretes GABA. Substantia nigra pars compacta secretes dopamine, pars reticularis secretes GABA, and subthalamic nucleus of Lewis is the only one which secretes an excitatory neurotransmitter, and that is glutamate. Now let's see what are the lesions. A lesion of the caudate nucleus produces chorea, flicking movements, involuntary flicking movements. A lesion of the globus pallidus produces athetosis, which are slow writhing movements. A lesion of the substantia nigra pars compacta produces Parkinson's. Loss of dopaminergic neurons produces Parkinson's. Lesion of the subthalamic nucleus of Lewis produces hemibalismus. Let's look at the next question. Depolarization phase of the action potential is due to calcium influx in which of the following? In a paraspinal muscle, this is what the action potential looks like. The depolarization phase is because of sodium influx. Paraspinal muscles are skeletal muscles, voluntary muscles. Cardiac muscle, the depolarization phase of the plateau potential is again due to a sodium influx. Extraocular muscles, these are skeletal muscles, voluntary, so they will also have a similar action potential as the paraspinal muscles, where the depolarization is due to sodium influx. But vascular muscle is a smooth muscle. And in the smooth muscle, the depolarization phase is not due to sodium, but due to a calcium influx. There are two tissues where the depolarization is due to calcium influx: the pacemaker cells of the heart and the smooth muscles. Smooth muscles of the GI tract, smooth muscles in blood vessels. Here the depolarization is because of calcium influx. The dicrotic notch on the aortic pressure curve. Now, what is this dicrotic notch? Now, this is what the aortic pressure curve looks like. At the first arrow is the start of the ejection phase. How does the ejection phase start? This starts with the opening of the aortic valve. Aortic valve opens. The blood will start moving now from the left ventricle into the aorta. This is what is responsible for that upstroke. When you look at systole, the first part of systole is isovolumetric contraction phase. Both the aortic and the mitral valves are closed. Left ventricle begins to contract. At the end of the isovolumetric contraction phase, the aortic valve opens, and then now starts the ejection phase. Blood from the ventricle will go into the aorta. So there is a rise in the aortic pressure. Then towards the end of the ejection phase, there is a fall in the aortic pressure. As you can see over here, this is because, why does the aortic pressure fall? Number one, there is slower ejection from the left ventricle because most of the left ventricular blood has already gone into the aorta. Ejection phase, there is a fast and a slow ejection phase. Most of the blood from the ventricle goes into the aorta in the rapid ejection phase. So the slow ejection phase, there is very little blood which is moving from the ventricle into the aorta, which causes a fall in the aortic pressure. And the second reason is the aortic blood which came into the aorta in the rapid ejection phase has moved forward. So there is a fall in the aortic pressure. Now, as soon as the left ventricular pressure becomes lower than the aortic pressure, the aortic valve closes. This is the point where the aortic valve closes. And when the aortic valve closes, that means end of the ejection phase. Ejection phase is from the opening of aortic valve to the closure of aortic valve. This is the ejection phase. Blood is getting ejected from the ventricle into the aorta. There is a rapid and there is a slow ejection phase. At the end of the slow ejection phase, there is closure of the aortic valve. Closure of the aortic valve produces the second heart sound. So this notch that you see in the aortic pressure curve, this is due to a closure of the aortic valve, and this is known as the Dicrotic Notch. It is known as the incisura on the aortic pressure curve and Dicrotic Notch in the peripheral arteries. Both mean the same thing, incisura and Dicrotic Notch. So a very interesting question, which valvular condition there is no incisura? Incisura is absent or the Dicrotic Notch is absent. This is in aortic regurgitation. So answer is C, that is closure of the aortic valve. The distance between two touch stimuli, the distance by which two touch stimuli must be separated to be perceived as two separate stimuli is the least in which of the following? This is called minimum separable. Minimum separable, and this is known as giving two pinpoint stimuli at the same time. This is called two-point discrimination. So minimum separable is least in the lips and the fingertips. It's about 2 millimeters. Back, this is 65 millimeters. What do I mean by that? That means if I give two pinpoint stimuli on the back, the distance between these two stimuli should be at least 65 millimeters for me to be able to perceive them as two separate points. If they are at a distance of less than 65, I will perceive them as a single point. But on the lips, on the fingertips, the distance between two pinpoint stimuli can be as low as 2 millimeters. I will be able to perceive them as two separate points if the distance is 2 millimeters. So minimum separable at the lips, fingertips is 2 millimeters, on the back is 65 millimeters. Out of the lips and fingertips, it's the least on the lips. So answer here becomes lips. Which of the following is the correct sequence of spread of depolarization in the ventricles? Now, when I look at the spread of ventricular depolarization, the first part of the ventricle to depolarize is the left upper part of the interventricular septum. And then the septal depolarization, this is left to right. Septal depolarization is left to right, and then the endo to epicardium. First, the endocardial surfaces will depolarize, and then the epicardial surfaces. And the last to depolarize is base of heart. Which cardium? Again, the epicardium. So the spread of depolarization, the correct sequence is going to be first the septum, then the endocardium, and then the epicardium. This is the spread of ventricular depolarization. Prolactin level is highest during which of the following? Now, a mnemonic to remember what causes increase in prolactin levels? Nursing, when the mother is nursing the baby. P, pregnancy. E, estrogen. T, TRH. S is sleep, NREM stages 3 and 4. Stress, strenuous exercise, sexual intercourse, breast stimulation. H is hypothyroidism. Hypothyroidism causes an increase in TRH. TRH will increase prolactin secretion. O is opiates. And P is phenothiazines. So, new pets shop. That is how we are going to remember the stimuli for the secretion of prolactin. Now, prolactin levels, do they increase 24 hours after ovulation? No. These are the conditions where the prolactin levels will increase 24 hours after delivery. Now, please understand, there is a steady increase in prolactin levels during pregnancy. There's a steady rise. At the time of delivery, now the prolactin levels begin to fall. And prolactin levels will reach the pre-pregnant levels in 1 week. But every time the mother feeds the baby, there is going to be an increase in prolactin. Please understand, this increase in prolactin will occur when the mother is feeding the baby, nursing the baby, not in the intervals between nursing. So 24 hours after delivery, I expect the prolactin levels to be high because I told you they will fall and reach pre-pregnant levels after about 1 week on the 8th day. In REM sleep, no. I expect the prolactin levels to increase in NREM sleep. 1 hour after running? No. During a severe exercise, yes, there is going to be increase in prolactin, but not after the exercise. So my best answer here becomes 24 hours after delivery.